and the NCD Alliance in implementation of PEN Plus. Thank you very much.
So did you get that? How did you involve community health workers and NCD Alliance into your PEN Plus? Please, can you give the gentleman, please, right here?
Thank you. I'm Robert from Tabora. I'm working under Akili Platform Tanzania. Saying that people connect people, I would like to ask one question to panelists, that how do we integrate palliative care in the concept of NCDs, but also what the role of SSOs in the way of awareness to the community, especially for those who are dealing with mental health awareness to the community. And last one, not least, how the issue of lifestyle can be implemented to children so that it can be a roadmap for preventing NCDs in the context of African countries. Thank you.
Thank you. The questions were well heard. I'll start with Arafa and then with Dr. Diwan, and then we'll go towards our panelists. As you're mentioning your reply, please give us a closing statement. So we want to have a closing statement. If you have a closing statement. Yes, please. Arafa?
Thank you so much, George. Can you repeat the question, please?
Yes, so I'm not going to repeat the question.
Sorry.
Yeah, so it was asking, I remember the question.
Okay.
Yes. How does stigma affect your access to care?
Wow. Thank you so much for that questions. Stigma, I have kept stigma on the back of my head because I believe I was very special to be born with the condition that I already have. So I made sure I really understand what's the reasons, how is it inherited, how should it be treated, what's my rights, and what should be done. So I don't let anyone who doesn't wear my shoes stigmatize me. So this is why I stand as an advocate, a very strong one, to make sure that all people living with NCDs are very strong and stand up to their rights, because nobody chose to have the disease that we have, but it just happened. So living with it is just the fact that you need to accept what you're going through. And if you can manage it and understand better your condition, it will even help you conquer the world. So
Thank you so much.
Thank you.
Thank you, Arafa. Yes, Dr. Diwan?
Yeah, thank you. I mean, in Bangladesh, you know, historically we have a very strong community-based health worker, and this because of this also we are very much successful in our EPI program and other primary healthcare program. But for this program, from the initial stage, the planning process also we try to engage the community-based health worker. And the many of the intervention package, social and behavioral change, communication package, everything we developed, and that was an inclusive process. We included the community-based health worker, and you know they're the prime at household level. They go to household level and visit household level, and they identify the cases, and then they refer to the primary level facility. So that's the way we engage the community-based health worker. Thank you.
Thank you so much. From the rest of the panelists, if you have any simple, short reply to the questions, please, Dr. Edna, over to you.
Thank you. I'll talk a little bit about transition. Okay, I said in transitioning, that's where we lose them. It's not that we have zero something we're doing. We have something we're doing. So what we're doing currently in Tanzania, we still have few clinics that have started transitioning. So and specifically in type 1 diabetes, what we do is an adult physician and a pediatrician, pediatric endocrinologist for now, they sit together in that clinic. And then you start seeing those age group 16 to 24 together. And that includes our nurses as well. So we have both pediatric and the adult side nurses doing the same clinic at the same time.
Thank you so much. Any other?
So my
No, 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 no.
closing
Yeah, your closing statement. Yes, yes.
my closing statement is diseases themselves are not our challenges. We have to make sure we provide continuity of care by providing access to diagnosis, treatment, monitoring, and follow-up.
Thank you so much. Dr. Judith, and then we'll finish
Yeah.
with Dr. Felix, your closing statement, and Dr. Terence, your closing statement. Yes.
Thank you. So transition, congenital heart disease can happen at any point. There may be adults here who even have congenital heart disease that is not diagnosed. So at the Uganda Heart Institute, because RHD will manifest overtly when it is advanced, we still see the children till 16. But when it comes to surgical decisions, we sit together. Now, the children want always to stay with their pediatricians. They don't want to cross over to the adult clinics. For congenital heart disease, we've had people who are biased towards adult congenital cardiology. But for RHD, the adults will take on and the peds take on the other side. It's still a tough decision.
Judith, it was
Palliative
closing,
care.
It was a closing statement.
It was answering. Anyway, palliative, someone asked on palliative care.
Okay.
Palliative care is holistic care, providing psychosocial support, and this can do at any point. Involve the families, involve the sufferers themselves, listen to their voices as they talk about their diseases, and engage the education system. Acting things like drama and music about the diseases reduces the stigma of the disease. My closing remarks
Yes, that's what I was.
are, it is possible for us to stop rheumatic heart disease because it's purely preventable. We can't stop sickle cell disease because we can also prevent by raising awareness. Type 1D may be tough, and congenital heart disease, but we can support families. Thank you very much.
Thank you so much. Just a complimentary to Judith, we can stop sickle cell through even parental screening before the condition. We actually can stop here. Yes, please.
Acts that we are living in a world with shrinking resources. So integration is pivotal, and for that case, we need to look at the opportunity available so that we start with reviewing the existing packages, and we make sure our healthcare providers they are aware with that. Let's focus on the reproductive maternity because it is a big population. Let's see what we address in all those elements in the continuum of care: pregnancy, labor and delivery, and post-delivery, and childhood and
Thank you so much. Dr. Terence, your closing statement, and as our UNICEF representative is giving us a closing statement. Statement, right? Perfect. I would also ask Dr. Mai from WHO Geneva to also come in front. Yeah, please.
Okay, thank you so much. So in closing, what I would like to say is no one visits a health facility more than a pregnant mother, a lactating mother, or children. So for me, integration is not even an option or a choice. It's actually actually the only choice that we have for us to go in terms of childhood NCDs. Thank you so much.
Thank you so much. Please, Dr. Usman, your closing statement.
A few takeaways from this, and we can add more or make them easier. I think the first and important one that came especially from all of us all the day, but also through Dr. Arafa, is that involvement of children and youth and people with NCDs and their families. I think that's the first and most important thing in this discussion. We should always work with these people and share their experiences and ensure that whatever their experiences are, we should design the services along and around and with them. I think that's the first thing. I had, and I like what was said yesterday and today by Raul, is Nike. I love Nike. Just do it. I think we shouldn't be in just developing plans or recognition and all that. With, the most important thing is to implementation, or we should act. Just do it, whatever it is, and then we can fine tune. Governments should strengthen primary health care based, child-centered, integrated care for children and children's onset NCDs. Partners, all partners and donors, we should strengthen and support governments. In integration, we should ensure integration in detection, early detection, diagnosis, treatment, and long care through MNCH platforms. And then also, I like what was said, the transition from childhood to adolescence, an adult it's not an easy thing, and it's something that has been missing. We should all look at that when we are talking about integration. We should leverage on existing platforms. We should not build, or we shouldn't encourage building new platforms. NCD should not be a new platform, but we should look at existing platforms in maternal, child health, and adolescent platforms. And we had very good examples, IMCI, HIV, there are many. We should work on those platforms. Referral between levels, community, primary healthcare, secondary and tertiary, but also between sectors and sections in health, in the hospitals. We should always remember community in all that we do. I think these are some of the platforms. Takeaways. Thank you.
Thank you, Dr. Mai, for your closing statement. Please have it as a closing statement before these people start calling me Mr. Closing Statement.
So good afternoon, everyone. It was great discussion, and I did like the fact that the panelists did not stick to the mainstreaming childhood condition into NCDs and IMCI programs, IMCH program, but actually it spoke to other issues. It spoke to what are the challenges, opportunities, and important consideration. And these are the ingredient of right planning. And as Duan said, maybe the first step is we plan it right. And I would like to add another layer to that. When we plan it, we need to consider also shift the discussion from primary care, the first level of delivering services, into primary healthcare approach, where we embrace its component, integrated services, community involvement, and multi-sectoral action. Therefore, we shift the discussion from diseases and programs to what are the community needs, what packages need to be delivered at certain levels of care, and then create multidisciplinary teams with sufficient skills that can deliver these services. So this is the spirit of the PHC approach, and I believe it responds to the needs articulated by Arafa and others who are affected by the disease. And I will end by citing Arafa, who said, we need health systems that hear us and grow with us. We need to grow with Arafa and others. Over.
So thank you to all our attendees, and thank you for your patience. So Now, to my closing statement. First of all, thank you, Rafa. You said something very strong that boldness counters stigma. And also, Dr. Judith said it is actually possible. And someone just said here, just do it. So all of this combined together with supportive structures. This session has been one of the best because of familiarity. When I look and I see a lot of familiar faces, we get very comfortable. I look and I see Guy Fons, who I met maybe in 2018. I was very curious to know who is Guy. And I look, I see Dr. Mary here, who is our PI for Pen Plus. I look and I see Dr. Kibasho, who we met in 2016. So there's a lot of familiar faces. But most importantly, when I look and I see my wife, Dr. Harriet. Yeah, so supportive structures, even in policies, are the most important thing for us. So when we're coming to a conclusion of our word for the day, do you remember it? NCD? NCD? Ebolaization. NCD ebolaization. Let us build supportive structures and let us just do it. Thank you very much, and we wish you a very good morning. I took my own bottle, yeah. NCD ebolaization.
So thank you very much for joining the great session for UNICEF. So I'm also reminded that NCD evaluation. So now we move back to the plenary session. So we'd like to start next session on the from policy to access from 12:30. Therefore, you only have a 5 minutes break, but please, Dr. Lisa and also Dr. Colin and also Dr. Anthony, Dr. Edona, and Dr. Thomas, please kindly be ready to start the session 3 from 12:30. Thank you very much.
Yeah, okay. So, pardon? That's me, that's me.
So we are fine. Oh, I mean, we try to keep 1 hour, but we think we can take up some part. That would be really appreciated. But so yeah, I have like a very quick 1 minute. Yeah. In my ask that I give it over to it won't take too much. Yeah. I think Paulina's presentation will also be just under that 30 minutes, so we should have maybe a few minutes for questions at the end. If we're still within time, would you like me to take questions from the audience, maybe one or two? Yeah, therefore, I mean, if you can take one part, including everything. So therefore, maybe I will come to you around the 120, and then so where are you sitting? I will try to maybe the question of the faculty. Yeah. Around the faculty, I will try to. Okay. Yeah. Great. I'll really try to rush it. Should we start now? Okay. Great. No problem. Great. Thank you, everybody. We're just being reminded that we're running behind time. So if we can quickly settle down. Gentle reminder to please get settled down as we get ready for our next session. We are running behind time. Thank you, everybody. Should I do a quick countdown? If anyone is still left after we count down to 0, we will have some punitive action. I'm going to count down now. 10, 9. Please, can we find our seats? 8, 7, 6. I will start calling names. 5, 4. Dr. Coffee and team, thank you very much. 3, 2, and 1. Thank you, everybody, and welcome back. I think that was a much needed break. Welcome to session 3, where we are talking about the transition from policy to access, focusing on essential medicines, diagnostics, and technologies for Pen Plus. My name is Lisa Rufaro Maroa. I am a senior manager for global non-communicable disease with the Clinton Health Access Initiative, or CHI. So CHI, as some of you might know, is a global health organization that works directly with governments and ministries of health across 35 countries. So you can find us in Africa, in Southeast Asia, and in Latin America. We are a mission-driven organization, and our mission is simple: to save lives. Our goal is not only to just deliver results during the life of a program, but we're also trying to work with governments to create systems that are sustainable and resilient, and will continue to work long after funding has ended. And I think we had a long discussion yesterday around domestic financing and resource pooling. Over the last 5 years as CHI, we've been working to extend our proven experience in HIV market shaping and trying to apply that model into the NCD space. So market shaping is basically us using collective power of governments and ministries to try and negotiate for lower prices for life-saving commodities. The work that we're doing now is building off of 20 years of HIV success. And one of the key milestones that we achieved is being able to market shape and negotiate pricing for HIV treatment or antiretrovirals from $10,000 per patient per year down to just under $60. So we're trying to bring these same lessons that we've learned in the HIV space now into the NCDs. And we've already started seeing some of these successes. Our NCD market shaping work, prioritizing access to insulin, hydroxyurea for sickle cell disease, and rapid diagnostics for diabetes and sickle cell. We've already started seeing some of these results, and I'm really excited that the CHI Ghana team is actually here to spotlight some of this work. We also have a couple of teams downstairs with their posters that can share a little bit more insight into the successes that CHI has achieved in market shaping for Pen Plus conditions. On price, we've seen a historic announcement that was shared last year, where CHI was able to work and secure the world's lowest price for rapid diagnostic tests, the hemotype SC for sickle cell disease,
We were able to negotiate a price where we reduced it from $8 per test to $1 per test. So now we're actually able to test more children than we were doing before. We've also negotiated a significantly reduced price for accessing hydroxyurea for low to medium income countries. So as you mingle outside with the Chai team, please find out how your country can access these negotiated prices. We've also created great impact around access and strengthening health systems. Across the 14 countries where Chai is working to implement NCD work, we've seen real gains in service access. In one integrated model, we've reported over 300% access increase to services. In Ethiopia, and I'm glad our partners are also here, treatment, care, and access for diabetes has risen by over 56%, and procurement for insulin has more than tripled. In Kenya, we were able to support the country in the establishment of their first type 1 diabetes guidelines. And as a result, we've enrolled over 1,000 children into care. So these are children that would have previously been missed. But we know that price and access only truly matter when the medicines are reliably reaching the patients who need them. This is why we're also trying to work to strengthen supply chain systems and building practical tools that country teams can use to prevent stockouts and support long-term access. The gap is not commitment. It is not political will. We are in the presence of senior leadership that's here to reiterate their commitment to the work that we've done in NCDs and to reaching the SDG goals. The issue is just around the systems. So how do we translate the policy or the political commitment into actual access so that each patient is able to access the commodities and life-saving diagnostics and medications that they need at the point of care? This session is going to highlight some of the interventions and innovations and country experiences that are working to close this gap. And they're going to offer us some practical insights for scaling and sustainability. I'm going to introduce, I'll hand over to Dr. Colin Pfaff from the NCDI Poverty Network, who will set the regional scene and talk to us a little bit more about the essential medicines and diagnostics for PEN+. Please welcome him.
Great. Thank you, Lisa, and afternoon, everybody. Thank you for attending this session. I'm Dr. Colin Pfaff. I'm the Associate Director for Programs for the NCDI Poverty Network. Next slide, please. So I have a fun job, I have to say. I took this photo in Malawi in February this year, driving to the PEN+ clinic, one of the 14 PEN+ clinics across the country. We saw elephants by the side of the road as we were driving to the clinic. Next slide. But for many of us working in the NCD space, the elephants are not only by the side of the road, but they're also in the clinic room when we arrive there. And of course, the elephant in the room of the clinic is where are the medications. Next slide. So this is a list of the top 6 items that our group considers to be the most essential and that we want to make a case for to be included in any PEN+ program. Next slide. And we chose these items based generally on 2 criteria: their lack of availability and their potential for impact. And this actually is a screenshot from our resource library, which Dr. Gupta also mentioned earlier. And I'm going to show you again the QR code so you can access these materials later. Next slide. So we're going to go through each of these commodities one by one. But firstly, I told you that we had selected these generally on the basis of their lack of availability. So these are 3 studies published by our group in the last 2 years, and they looked at the baseline availability of these products in the 9 countries, or 9 of the countries where we are supporting PEN+ implementation. And you can see there's quite a lot of variability between sites, but in general, there is more than or less than 50% availability for almost all of these 6 items. And those of you who work in the clinic space will agree with me that that is very much the situation on the ground. Next slide. So we're going to go through each of these items. This is number 1, that we have. Number one is glargine, or the long-acting analog insulin, available in a pen device. And the advantage of this commodity is the analog itself reduces the risk of severe hypoglycemic events, and the pen device makes it much easier for patients to deliver the insulin to themselves. The photograph is of a 29-year-old woman in Zimbabwe who we saw a year ago. She had been admitted to the district hospital for 4 weeks on the usual regular human insulin, and they had been failing to manage her severe hypoglycemia. So the Pen Plus team was able to change her to a glargine pen. I need to say she's also almost blind from cataracts in both eyes and has extremely poor social support at home. So the Pen Plus team changed her to a glargine pen. Her hypoglycemic episodes in the hospital were settled within 3 days, and she was discharged on day 4. I saw her again this year, 1 year later, and she is doing very fine at home. She has not yet been referred for her cataract surgery, although that's being planned. So even with her poor vision, she was able to manage very well to deliver her insulin device using the pen device. All right, so that's number one. Number two might be a surprise to you, glucometers and glucose test strips, which surely every facility in a whole continent almost has. But what we don't have is quantities that are sufficient for patients with type 1 diabetes to take home and to manage their own glucose monitoring at home. And without that, it's almost impossible to really manage these patients to a reasonable high quality or standard of care. The photograph is of a 2-year-old child in rural Malawi. He was diagnosed with type 1 diabetes at the age of 2. He's now about 4.5. He was diagnosed at a rural district hospital about an hour and a half from the capital city, and he has been managed up until now almost entirely by a team of non-doctors, so clinical officers and nurses at the rural district hospital, the Pen Plus Clinic. And the reason why they've been able to manage him so well and adjust his insulin month-to-month basis is that the mother is able to monitor his glucose every day, 3 or 4 times a day, using the glucometer and the logbook that you can see. We have to increase the amount of supplies that are available in our hospitals to enable this to take place. All right, next slide. So number 3 is these rapid point-of-care sickle cell diagnostic tests. So this has been quite a revolution in the last 3 years. Prior to the implementation of these devices, in a rural district hospital, the main way that sickle cell disease would be diagnosed was through a microscopy test, which has very low sensitivity and specificity. It means that you're probably missing about 40% of the patients when you do the test, and you're also overdiagnosing patients because you can't tell the difference between a trait and someone who has the disease. And as such, you can't really use that test to start hydroxyurea. So there are 3 of these, 3 different brands or types of these rapid point-of-care tests that are on the market. They've got extremely high sensitivity and specificity, 99%, that can be done at the bedside. What happens when you release it into a community? This photograph is from our Pen Plus clinic in Mozambique, rural Mozambique, I need to add. It's over 2 hours from the nearest referral hospital. We were told that there are no patients at all with sickle cell in this community. When we introduced this test within 2 years, we found 29 children who have sickle cell disease, increase in school attendance in our patients who are receiving hydroxyurea. It's relatively cheap, but most countries, it's not available outside of the capital cities. Next slide. Item number 5 is these point-of-care echocardiography machines. There are many different brands on the market, and there is some guidance, again, in our resource library. That's a screenshot there, maybe of the disadvantages and the advantage of the various different machines. This has really changed the whole nature of echocardiography and put this form of investigation into the hands of nurses and clinical officers in a rural district hospital, meaning that diagnosis can now be done far away from the cardiac centers that are mainly concentrated in capital cities. Just to give you an example, at our Pen Plus site in northern Tanzania, they have in the last 2 years diagnosed 55 patients with severe chronic rheumatic heart disease, and several of them have been referred here to Dar es Salaam for cardiac surgery. So none of that would have been possible without this technology. Okay, and lastly, I feel almost a bit ashamed to put this on the slide that we are really sitting in 2026 and we are saying we don't have steroid inhalers for asthma at the primary healthcare level. If you look at any international guidelines about asthma, this would be the cornerstone of treatment. But if you go to primary care across the continent, it just isn't there, and people are being managed on oral medication. This is a young girl from our clinic in Zambia. She was managed largely on oral drugs until she came to Pen Plus and was able to be put on a steroid inhaler, and her treatment course has completely changed. Next slide, please. So those are our top 6 items for inclusion in a Pen Plus facility. Why are these items still not available in 2026? So there's 3 main barriers that our group has identified, and they also offer maybe pathways as a group to find solutions. So the first one is looking at policy barriers. We looked at 10 of the countries where we are implementing or supporting the implementation of Pen Plus clinics. And the first question we ask is how many of these countries had these products included in their essential medicines list or in their standard treatment guidelines? And you can see there only 20% of those countries had the sickle cell rapid diagnostic test in their standard treatment guidelines. Only 60% had glargine analogs. So there's a pathway for something for us to do there. And even more worrying, perhaps, is looking at the national health insurance packages in each of these countries. And what you can see of these 10 countries, somewhere between 10 and 30% of those countries actually had these items included in their national health insurance packages. Again, a clear pathway for us to take action. I think what this group needs to take very seriously is the pricing of these commodities. What we did for these 10 countries was look at the prices that our implementing partners were paying and comparing that to benchmark prices, which we got from UNICEF, from other country supply lists, and from various other sources. We had benchmark prices. And what you can see here, these prices vary widely, but look at the huge increased prices that our implementing partners were having to pay and are paying even today as we speak to have these items in the country. Glargine up to 7 times more than the benchmark price. Glucose strips up to 6 times more expensive. Steroid inhalers 5 times. And hydroxyurea in some had a 12-fold price variation. Our pharmacist on our team constantly reminds me that it's not just about price, that we also must remember in any discussion about price, you have to keep quality in mind, and especially bearing in mind that many of our contexts, the quality regulation environment could be much stronger. So that needs to be an important thing to consider as we push for price and we have an emphasis on lowering price. Next slide, please. So our group has put together and is putting together a best practices guidance for Pen Plus implementation. And I had 6 items for you. I've got 7 best practice guidance, or 7 action points, can I say. So the first one is around fair pricing. And we are especially suggesting targeting the products of glargine in pen devices and glucose test strips. Glargine really has to come down in price before it's going to be affordable by national governments. Secondly, these prices that people are paying are largely invisible. It's very hard to actually find out what governments and other entities are paying. But if we had better price transparency, that is a next step towards driving down the price when we actually know what people are paying. I mentioned earlier that it's not just about price, but our team is also working to try and support our implementers with suppliers that are quality assured so that whatever commodity we're buying, we make sure they're of good quality. Number 4 is something that I personally feel quite passionate and even frustrated about, I must say. Much of our drug forecasting around these commodities has been based traditionally on consumption-based forecasting. So if you only supply a clinic with a very limited amount of commodity, that is all they consume, and then in the next ordering cycle, that's also all that they get ordered, because their forecasting is not based on patient volume, but it's based on consumption. And I think this is a key message that we need to get across at all levels, Just as the HIV program did, we need to be basing our drug forecasting on patient volume. Number 5, many of these products are actually probably suitable for pooled procurement mechanisms. And the 2 items we selected here are the rapid diagnostic test for sickle cell disease and for hydroxyurea, where actually volume can probably secure bigger quantities of drugs and supplies and drive down the price. And the last 2, developing a quality assurance policy as part of this practices guidance, and then also a group of stakeholders that can have a collaborative approach to taking this guidance forward. Next slide, please. This, again, is the QR code with a link to our resource library. So you could take that on your phones if you want to look at some of the tools that we've referred to in this talk. Next slide. Lastly, I want to say, I think we need much more advocacy on the issue of access to drugs for severe non-communicable diseases. Many of us in this room were involved in the fight against HIV and AIDS. This is a photograph taken in my hometown of Durban, where people were demanding access to medication. And I think what we forget now, almost 20 years later, is that the fight for HIV/AIDS was actually a fight for medication. Before it was a fight for anything else, it was a fight for drugs. Next slide. And I think we are in the same era in dealing with the issues around severe non-communicable disease. We need more noise in this room. We need more activism and passion in this room to be fighting for access to commodities. For example, the activists here have been pushing for insulin pens to be priced at $1 each. So I would like to close with a story that I heard from one of our from one of the countries where we are working. It is the story of a youth advocacy organization that is working with patients with type 1 diabetes. And they received funding to make bracelets, these medical alerts, insulin or diabetes bracelets for young people living across the whole country who had type 1 diabetes. So they contacted various hospitals across the country and they got names of young people living with type 1 diabetes because they wanted to engrave the names of the people on these metal bracelets and then go to the hospitals and then give them out to these young people. So that's what they did. About 2,000 bracelets they made. And when they went out to the hospitals, what they found was that somewhere between, in some hospitals it was 1%, in some hospitals up to 9% of the people that they had named bracelets for, they were already dead. And they were dead largely because of lack of insulin. So, ladies and gentlemen, I have brought with me some bracelets today. And I've brought with me these bracelets for us to remember these young people who lived and died with type 1 diabetes, who died because of lack of access to these commodities that we're talking about in insulin. I'm going to leave these bracelets on this podium for the rest of this talk because I would like this to be a reminder to us all today that we need to take this issue much more seriously. Thank you.
Thank you, Dr. Colin. I think that's a very sobering end to this overview. But it goes back to the statement that we heard earlier and yesterday as well, reminded that 73% of preventable deaths that are due to NCDs are happening where we live, where we work. So it's up to us to beat that drum on NCDs and raise the awareness, lobby policyholders, lobby budget makers to prioritize these commodities, these life-saving commodities. I'll move on to our next presentation, who's going to give us country context. So this is our example from the Ghana office, where we have my colleague from the Chai team, Dr. Dogbedo, to come and share with us the experiences. Thank you.
Thank you, Lisa. Good afternoon, everyone. My name is Anthony Bless Dugbedu. I work with the Clinton Health Access Initiative in Ghana. Lisa has already given organizational context as to what CHI does, and so I will not belabor that point. So as we gather here, I'll just go through with you a couple of slides and looking at what we are doing in Ghana to improve access to diagnostics and treatment for sickle cell. Next slide. We'll look at the burden of the disease. We'll look at the tools that we have deployed, and then we will look at the results that are coming through. Next slide. CHI, by now you already know that we work with the government, not a standalone program. We deploy 4 strategic approaches in our work with the government. Lisa has mentioned them, but just to emphasize again that we are a strategic partner to the government, and as a strategic partner, we support national planning, and as an operational partner, we support on-the-ground delivery of all government programs that we are involved with. As a market shaper, we work across the globe to reduce access prices and make them affordable for both diagnostics and therapeutics. And as an ecosystem catalyst, we work with other partners in the space to leverage and strengthen programs across the country. Next slide. Sickle cell disease, by now, we already know. These are genetic blood disorders that are inherited, transferred from parents to their offsprings. Important to know that 7 million people live with sickle cell in the world, and 80% of them are found in sub-Saharan Africa. Every year, more than 500,000 babies are born with sickle cell, and 79% of those babies are born right here in African among countries that are sitting here. For a lot of these babies that are born, the prognosis is very severe. Up to about 90% of them die before age 5 without any treatment. But there are interventions. The diagnoses are there and the treatment is there. They are not so expensive. So why do they keep dying? Why do they remain undiagnosed? On our path to meeting SDG 3.4, this sickle cell challenge remains, and we need to address it. If majority of the people with sickle cell are found in Africa, then Africa must lead the response to addressing sickle cell. Next slide. To understand how diagnosis used to be in Ghana and what we are doing now, it's important to highlight what the situation was. And so in Ghana, before point of care testing, sickle cell disease diagnosis was built around major facilities, major central hospitals and central laboratories. This meant that families have to travel long distances to these facilities. Samples have to be pulled together and sent to the laboratory. Families would have to go back home and given a time to return. This time often takes 15 to 30 days. And the tools that were available were IEF and HPLC. The situation we found ourselves in at the time was that most families do not return. And so a lot of missed babies, a lot of children go undiagnosed. But also, the system alienated district and community level facilities from the process and limited their role because these tools were not available at that level. And so most of the diagnosis then was reactive. And so patients, children would be diagnosed either when they encounter serious and severe episodes or at postmortem. Why would people have to travel long distances for a simple test? Dr. Collins has showed us some of the tests and how they can be deployed. Next slide. And so in Ghana, many tools are being deployed, but I would like to highlight two of these tools that are very critical and are changing the landscape for sickle cell diagnosis. The lateral flow assay LFA, like hemotype SC, gives you a result under 5 minutes with a single heel prick. You don't need electricity, you don't need cold chain, and you don't need any special equipment to have that test done. It's very sensitive for HBSS and HBSC. And this has been validated across many African settings. The second tool is the Gazelle device. In Ghana, we have deployed this for HBF monitoring to complement testing from hemotype SC. This has been also integrated and specified in the Ghana Case Management and Screening Guidelines. It can precisely quantify genotypes and differentiate them. In some facilities, in the absence of HPLC and IEF at the higher level, they also rely on Gazelle as a complementary tool. At the time of deployment, some of our healthcare workers who were trained were impressed with how precise these tools could be and the results that could be channeled from them. And I'd like to highlight just two of those testimonies from one of our doctors who was trained and for the first time having seen the hemotype SC and how to use it. And so in that picture, trying to screen a baby and how that has changed her mindset when it comes to sickle cell screening across the lower levels. Similarly, we have hematologists from some of our district level facilities attesting to the usefulness of the Gazelle device. Next slide. And so our response can be characterized and articulated in 3 bucket areas: market access, service delivery, and ecosystem strengthening. We have mentioned this before. And I'd like to go back to the point Lisa mentioned earlier. Across 3 countries, we have worked with global partners to reduce the price of hemotype SC to $1. This is about more than 40% reduction in access price. HU, hydroxyurea, is now under 15 cents in about 8 countries. In Ghana specifically, and I go back to Dr. Collins, who talked about including hydroxyurea in pool procurement. It's interesting to note that in Ghana, hydroxyurea has been included in the framework contract for pool procurement. Again, there is an expanded NHIS coverage for STD package of care. This is a process that is currently ongoing for the National Health Insurance to not just cover aspects of the treatment and aspects of the diagnosis, but cover the whole continuum of care for sickle cell. We have worked with the government to build and establish a hub and spoke model, meaning higher level, higher functioning facilities at a district level can offer screening, diagnosis, and treatment, and support lower levels at that same level to do the same across board. We have supported the government to develop and launch and roll out screening and case management guidelines and training materials together with job aids. The capacity of many healthcare workers have been developed to enable task shifting. Again, as part of ecosystem strengthening, sickle cell disease technical working groups have been established. Ghana has declared in 2025 sickle cell as a priority disease at the UN General Assembly. We have supported government to integrate. We talked about integration in the last session. Sickle cell disease data management has been integrated into an NCD all-encompassing data management system and platforms in the country. In Ghana, we have supported government to deploy a focus program for children under 5. These children come through all the maternal and child health entry points that we discussed earlier in various presentations. And so at the maternity ward, at the labor ward, at OPD, at NICU, and all the reproductive and child health entry points, children are being screened and are being identified. Next slide. It's important to also just mention that we have rolled out this program with government, and in about 2 months, barely 2 months, we are already seeing progress. As of the time of preparing for this conference, over 4,000 children under 5 have been screened across 13 facilities. As of this morning, as I was preparing to speak, over 5,000 children have been screened across 20 facilities. 30 facilities are now offering point of care testing across 11 regions. These are district level facilities and community level facilities. Over 360 healthcare workers have been trained across more than 6 cadres. We talked about training healthcare workers. In Ghana, what we are doing is not just to train one healthcare worker per unit. So if you take the OPD nurses, child welfare clinic nurses, you would find that more than 3 people have been trained. If one person is not available, the other is available. But also the idea is for them to go back to the facility and cascade this knowledge down to their colleagues. Many of our facilities have since done that. And so overall, a turnaround time that used to take 15 to 30 days has been reduced to under 8 minutes for diagnosis and enrolling children in care. Our trajectory from looking at the 2 months of activation points to over 116,000 children that are going to be screened in the next 12 months. We are looking at correctly diagnosing over 1,800 children and enrolling over 1,100 children in care. We are expecting that over 1,500 children will be initiated on HU and over 1,000 children will be retained in care. Next slide. We often say that diagnosis without treatment is unethical. HU helps to minimize severe adverse effects. It is a single dose drug, oral medication, that can reduce mortality and painful episodes. Yet many children who are diagnosed do not successfully transition into sustained care. We talked about transitioning in the last session. In Ghana, we have built a pathway to retain children in care. This is to address the fragmented facility procurement. Dr. Collins talked about fragmentation of procurement for commodities. Prices, I will not belabor the point, we have talked about it. Prices for brands are higher than national health insurance in most countries can reimburse. Supply chain fragility limits access, and then prescribing in Ghana, particularly prescribing authority for hydroxyurea remains at a specialist medical officer level. And so any medical officer that has not specialized cannot prescribe hydroxyurea. We have deployed a 5-prong pathway to putting children in care. You screen, you do a baseline test at a health facility, and immediately enroll in care and give supportive counseling. Put that child on treatment together with adjuvant therapies and ensure that that child is retained in care through peer giver support, education, and monitoring. Next slide. Specifically on hydroxyurea, despite NHIS increasing the tariffs from 19 cents to 30 cents, there are efforts that are underway to close the remaining gap. We are currently working with the Ministry of Health to ensure that not just hydroxyurea, but also the screening is included holistically in the NHIS. There is already a framework for pooled procurement. Next slide. Next slide. Great. Over the course of the program, barely 2 months, we have noted a number of lessons, and we just want to highlight them for this room. Many of them may apply to other countries that are here. Government ownership. In Ghana, government is everything. If government is in the program and leads the program, be very sure that it will be successful, it will be sustained. And as we have come to know, China does not deploy parallel programs. So we support the government to leverage its own existing systems and build on those systems and make them stronger. Integration. We cannot belabor the point of integration. Attaching sickle cell screening to all immunization and maternal and child health touch points proved very, very successful. And so wherever babies are coming through, they are being identified. There is no single entry point for identifying sickle cell. Deploying POCT at the primary healthcare level, that is district level and everything below it. Training and mentorship is very vital. And data management cannot be overemphasized. The demand side is very important. Community awareness and ensuring that people have knowledge to support one another at the community level and refer is also very key. Next slide. As I wrap up, I just want to highlight a few questions for the room. For our policymakers, we are asking that you include in your national NCD packages and newborn health protocols sickle cell screening for early identification. It should be treated as a standard of care, not as a pilot program. For our partners and donors, please fund the linkage to treatment and monitoring, not just the test. The screening is just one part. And so the treatment is the second part that needs to be funded. For WHO, we ask that you formalize point of care diagnostics within the PEN Plus essential diagnostic list and build SCD registries across PEN Plus countries. As I close, next slide. I just want to say that every child with SCD deserves to be seen, diagnosed, and treated, no matter where they were born. Distance should never be a barrier. Thank you.
Thank you, Anthony. Really encouraging results that we're seeing from Ghana. Just goes to show that we need to work together with government and the advocates themselves to be able to negotiate these prices, but also ensure that the commodities are available where they are needed. I think one of the key things that he mentioned was we need to sort out the demand side as well. So if we're pushing for these tests to be put in the facilities, hopefully government will be able to listen to us. We'll hear from Dr. Edna Mojali from Tanzania, who will speak about the type 1 work that they've been doing, especially around insulin and analog insulin. Thank you.
Thank you. Good afternoon. Thank you everyone for attending the session, and thank you organizers. My name is Edna Majaliwa. I'm a pediatric endocrinologist, but I'm going to talk to you on monitoring and use of analogs. So As you see, the title is Improving Outcome in Type 1, the role of insulin analog and self-monitoring of blood glucose. Next. Next. So we all know what type 1 diabetes is, I'm sure. And we know it's lack of insulin, so we have hyperglycemia. And so in type 1 diabetes, we use insulin as a lifelong treatment, and we use it for survival, not for control. So when you combine it with self-monitoring blood glucose, you've provided a foundation for good glycemic control. Then you've prevented complications. Next. A bit of epidemiology, but this is general diabetes, where we have about 588.7 million people with diabetes. When you talk about type 1 globally, there are 9 million, but we have about 2 million, more than 2 million in low middle income countries. And the peak age is 13 to 14 and 5 to 6. And we're seeing more of under 5s with type 1 diabetes now than ever before. Next. It's the same thing in a map, but you can see in the blue line, it's not consistent, and so the treatment outcome is not the way we would love it to be. So the question would be, should the low middle income country expand access to analog insulin? Next. A little bit of incidence in Tanzania specifically. We have about 2 per 100,000 population. And if you look at that incidence and look at Finland, they're like 52.2 and they're type 1. So what is happening in sub-Saharan Africa? Is it that we have really low incidence? Are we missing them? Do we have a lot of undiagnosed kids? And do we have a high mortality because the awareness is low? Or what is the issue? And most of our data, remember, it's hospital-based. So we need to do something on data, and then possibly even the commodities will come lower. Next. So when we say analog insulin, what do we mean? The analog insulin is the human insulin, but has been modified. So to make it either work faster or work for a prolonged period of time, but at a steady level, so they do not have peaks up and down. And so they either act very rapidly or they act steadily, and they have a prolonged effect. We have type of analog insulin, which are the fast-acting, very fast-acting, and long-acting analogs. Some of the names are there. Next. That slide is a bit congested, not a bit, it's really congested. And currently we are using human insulin, which is commonest. I know we call it NPH insulatard or lente, though it is not really lente. And we're using soluble or regular insulin. But then when we use these two, we have risk of hypoglycemia than when we use the analog insulin. Then even the onset of action is longer than if you use analogs, and then the peak is pronounced, so the effect of hypoglycemia is very high in the human insulin when you compare to the analog. And remember, when you say hypoglycemia, that if the risk, so the nocturnal hypoglycemia is even more. So we have a risk of losing our babies at night because not everyone wakes up at night to check what is happening. The analogs are more flexible, so you can inject and eat immediately, but then the regular one, in the human insulin, you have to wait for some time. And the analog are more convenient and easier to take. But then availability, it's more available. The human insulin in our setting is more available than the analog insulin. When you talk about the cost, so the initial cost of buying a regular insulin is cheap, but when you put in the what is happening, the rate of hypoglycemia, admission due to hypoglycemia, then admission due to hyperglycemias, and that flexibility that is missing, then the cost of the human insulin becomes higher than the cost of analog insulins. Next. So there's some few studies that have been done in Africa. There's this study done in Mali where they compared the two groups, the human insulin, long-acting, the NPH, not really long-acting intermediate, and then they used biosimilar glargine, and they compared the outcome at 12 months. They are looking at the glycated hemoglobin. That tells us how the glycemic control is. And they found out by the end of 12 months, those who were on glargine were well controlled, were better controlled. They had a drop in HbA1c from 12 to about 8-9%. And so they're measuring the HbA1c every 3 months, but so the effect had been there up to 1 year. Next. There's another study that was done in Bangladesh, and they had a reduction of about 0.5%. And by the end of the study, by the end of 1 year, they had 7.8% from 8.3%. Next. This table, you may not see the numbers, but it is showing the number of nocturnal hypoglycemia in patients who are given glargine and in patients who are given human insulin. So this is specifically for glargine, where there are less nocturnal hypoglycemia compared to those who are getting normal human insulin. And the severe hypoglycemia was even less when they compared with the human insulin. Next. So in those studies, some of the studies, they did a qualitative study, and this is what patient had to say. So the health professional was reassured that this child is doing well, and the children were like, they were not doing something, and now they're able to do something. They're able to go to school because they're not getting any more hypoglycemia. They're not getting hyperglycemia. The problem with NPH, sometimes you can't predict if you're going to get hyperglycemia or hypoglycemia or not. You might use same dose, same everything, and you still get an hypoglycemia. So it has very high variability when you compare to analog insulin. Next. So self-monitoring of blood glucose. This is your daily measuring of blood glucose, and you need them to measure pre-meal and after meal, and you know. So, and you use it for adjusting insulin doses, detecting hypoglycemia, monitor sickness, and guide on your exercise and nutrition. But then a clinician would use this for change insulin regimen, decide how the reliable glucose data is, reduced emergency admission, and then better HbA1c. So, which will add a time in range to complement to the HbA1c. Next. And so the devices we use for monitoring, we have glucometers and CGMs, and most of our patients have CGMs, very few have, most of our patients have glucometers, very few had CGMs. Next. So on comparing the glucometers and the CGMs, I'm going to skip this, but the CGMs, you get a pattern, and in glucometers, you get at a point on time. And in glucometers, you get it now, but in the CGMs, you get a longer time, and you can predict what is going to happen. Next. What I would say initially in the CGMs, the cost would be high, but when you compare that, you're able to predict the hypo, you're able to predict the hyper, so you'll know when you're going to hyper and prevent them. Then when you are doing the glucometers and you're using needles, you might not know, you find yourself in hyperglycemia or hypoglycemia. So you have frequent hyperglycemia, frequent DKA, frequent hypoglycemia, and the cost becomes higher in a long term when you compare to CGMs and glucometers. And here are the two readings. In the glucometers, we are writing on a diary, and we have to write at a specific time. But when you look at the CGMs, they'll tell you the pattern. They give you this a high, and 70% this child was in normal range, time in range, and he had hypoglycemia about 3.9 millimoles, but was not going to, it was steady. It is not going fast. So you get more information in CGMs than what you get in the glucometers. Next. Okay, they're telling me times, my time is over, but why do we need insulin analog? I'm going to go a little bit very fast. We need, because it is flexible, it is more reliable, it doesn't have peaks, the variability is lower, so it gives you a good glycemic control when you compare with the human insulin. The affordability might be high initially, but when you compare to the complication that happens with the human insulin, then the cost becomes better with the analog insulin. And so the complications are lower in the analog insulin. So, and we all know using insulin without meters is unsafe, but then meters without insulin is also ineffective. Next. So we recommend to prioritize high-risk group, the children and young adults, and improve availability of analog insulin. We saw from Collins that there are 40% unavailable, and then possibly procurement system has to be strengthened. And we have the medium term to include the analog in the national essential medicine list, expand insurance coverage as well, then have universal access to quality type 1 diabetes care, sustainable financing models, and integrating the Pen Plus services. Next. Okay. I'm stopping your take-home message. So optimal type 1 diabetes care require both effective insulin therapy and accurate glucose monitoring. And we've seen analog insulin offer a better glycemic control. In low middle income country, access of analog insulin and SMG is a major challenge, but it can be done. So we need to expand availability, affordability, and education and health system support to the people living with type 1 diabetes, and so that they can benefit from these technologies. Thank you.
Thank you so much, Dr. Edna. Apologies that we've run out of time. We have one more speaker who's joining us from online. It's Dr. Thomas Aldersley, who will speak about pediatric and congenital heart disease services in Africa. He has 5 minutes to share his presentation, but after this, we'll share the materials with you, and you can reach out directly to the speakers. Thank you. Please may you connect, whoever's controlling the teleprompter, please can you connect Dr. Thomas? Thank you. Dr. Thomas, can you hear us? Checking, Dr. Thomas, can you hear us? Apologies, we're eating into lunchtime now. Thank you, he's online. And I think confirmation that the guys can hear him. Tech team, can we get sound in the room as well? So it seems those with their headphones are able to hear him. We're just trying to get the sound into the room as well.
Hello, can you hear me?
Thank you. We can hear you now. Please get into your presentation. 10 minutes. Thank you.
Okay, I can't hear the room, but apparently you can hear me. So I'm just going to go ahead. Thank you so much for the introduction. It's a great honor to be part of this important event and such a pleasure to see the amazing work that's being done in NCD care. I'm going to skip the introductions to try and make up some time, but I'd like to discuss the current landscape of PCHD services in Africa, some of the challenges that remain, and one possible framework for thinking about future scale-up. Next slide, please. So congenital heart disease is the most common major birth defect worldwide. And is responsible for more deaths than any other congenital anomaly. Similarly, rheumatic heart disease is an important cause of morbidity and mortality, especially across Africa. And both of these conditions require specialist cardiac services, yet access to those services remains unequal. And so the challenge becomes more than just burden of disease, which is high, but the ability of the health systems to provide diagnosis and adequate treatment. Next, please. So Pen Plus represents a major opportunity, and if successful, is going to strengthen diagnosis and management of severe NCDs at first referral hospitals. But when you view that through the lens of pediatric cardiology, success creates a new challenge. More children with heart disease will be recognized, and more will enter referral pathways, and more will require specialist cardiac services. So the question then becomes whether our current systems are ready for that increase in demand. Next, please. And to answer that question, we need to first understand the state of pediatric congenital heart disease services across Africa. And to do that, we conducted a landscape analysis of these services, which included 124 respondents from 96 institutions across 45 countries. Next, please. And the findings revealed substantial gaps. Next. While 78% of countries reported some form of cardiac service, next, only 40% reported access to comprehensive pediatric and congenital heart disease services. And although 27 countries reported having pediatric cardiac surgery, many of these lack cardiopulmonary bypass facilities, which severely lacks the complexity of the surgery that can be performed. Next. The workforce findings are perhaps even more striking. International benchmarks suggest approximately 2 pediatric cardiologists and 1.25 cardiothoracic surgeons are needed per million population. Next. But across Africa, the median density was only 0.17 pediatric cardiologists, next, and only 0.04 pediatric cardiothoracic surgeons per million. So no region approached international recommendations for cardiothoracic surgery and few for pediatric cardiology. We also assessed the institutions against the Hassan et al. Guidelines for pediatric cardiac services in low and middle income countries, and no institutions met criteria for level 5 or top level referral centers, and few for level 4 referral centers. And I'll just explain these figures next. These are radar plots, and each axis represents a domain, a service domain from human resources, services, infrastructure, training, health information systems, and the proportion of centers meeting these top-level criteria are mapped along these axes. Next. You then join these points together in a polygon for each of these regions, and the larger the polygon, the more institutions that are meeting these higher level services. Next. And an uneven shape in that polygon will indicate imbalance between the domains and areas of strength or potential area targets for intervention. Next. The Southern African plot in dark gray is symmetrical, and it's indicating that there is no category that is lacking, and that a generalized expansion of services is warranted. Next slide, please. But the Northern African and Eastern African in red and blue polygons are similar, but they've got a lower proportion of centers with slightly more asymmetry. Next slide. In contrast, Western Africa shown in yellow and Central Africa shown in green demonstrate more pronounced deficiencies and imbalance. Next. And these deficits are not confined to just infrastructure. They extend to things like workforce, training, and services. And that suggests that simply purchasing more equipment is not going to solve the problem. Next. And the training data that we have reinforce this concern. Only 44% of countries, next, report having fellowship training programs. And next, and across the continent, we identified relatively few programs, and they were only producing relatively small numbers of specialists each year. So in other words, this workforce gap is not going to be addressed with the existing training pathways alone. Next. And so our landscape analysis, next, highlighted, we're going the wrong ways. Next, substantial gaps in the workforce, infrastructure, training, and service capacity. Next, and at the same time, initiatives such as PEN Plus are likely to increase demand for specialist cardiac services. And this leads us to the next question, which is, how do we scale? And there are several possible approaches, and I would argue that we should work on all of them simultaneously. But one of those is potentially to regionalize some of the complex services. But to help answer these questions, we've recently launched the Acacia project, which is the Cardiac Surgical Resources in Africa project. And it aims to map cardiac surgical capacity across the continent to understand those referral networks that exist and training pathways, and to generate the evidence that we need to inform future development. And one potential solution that Acacia will explore is regionalization. And I'd like to unpack that. Next, please. So regionalization, as you know, is the concentration of specialist services in a smaller number of centers. And the concept isn't new, and there are both valid arguments for and against. And the discussions we've seen already demonstrate the extreme value of the decentralization of certain services in expanding access to care. But when you move beyond diagnosis and initial management into highly specialized definitive interventions, you need to have taken other considerations. And what I'd like to discuss is whether regionalization might have a complementary role in helping deliver those services. Next. And internationally, this tension is recognized, and experts have attempted to identify which services are best delivered locally and which would benefit from concentration. And this Delphi consensus proposed the optimal organization of services based on complexity, volume, and acuity. Next. And in this framework, high volume, low complexity services would be recommended for decentralization, whereas the high complex, relatively low volume procedures should be regionalized. But the question is, where does congenital cardiac surgery fit into this framework? Next. And there is a lot of variation in the procedures that we do, but in general, we occupy the high complexity and relatively low volume end of the spectrum. And in this framework, that's precisely where regionalization is most common. Next. And this isn't a theoretical, this isn't just theoretical. There are many countries that have adopted a regionalization, like Sweden and the United Kingdom. Next, but importantly, an important example is the Slovenia-Slovakia model, where they use cross-border referral of complex neonatal cases to enable treatment and expertise despite relatively small national populations, demonstrating that international regionalization can work. Next slide. Next, but Africa's challenge is fundamentally different to that in Europe and North America, as many countries they have limited diagnostic capability with little to no cardiac surgery programs. They've got low procedural volumes and limited training. And the challenge isn't just about concentrating services, but building expertise and capacity, and how to do that as efficiently as possible. Next. And at the same time, most of these countries are not like Slovenia and Slovakia, and they have populations that should justify ultimately national programs. Next. And can you go? And sorry, it's fine. One possible approach is to look for cross-border regionalization, but then to view it not as a final destination, but rather as a stepping stone. Those regional referral centers could support the neighboring countries while capacity develops. And as volume and capacity grow, those countries could progressively transition towards their own independent national programs. Next. The critical point being that those referral hubs don't just receive patients. They function as engines for building capacity through training, mentorship, and things like shared research and clinical systems. Next. But if regionalization is to occur, we need a transparent way of identifying those centers and then of supporting them. And we believe one possible approach is an African accreditation framework that's developed collaboratively by African stakeholders and professional societies. And this framework could define levels of capability, establish standards, recognize excellence, and support programs as they mature. And important is that they would recognize that it's a continuum of development and not a simple pass-fail. Next slide. And Acacia hopes to contribute to this project, because before we can do any regionalization or accreditation or designate those referral hubs, we first need reliable data. And Acacia hopes to map cardiac surgical programs, to characterize capacity, and identify those referral networks, to provide evidence to support future decisions. Next, and to wrap up, there are significant gaps in pediatric and congenital heart disease service, and they persist in Africa. And Pen Plus, next, is likely to increase demand for specialist cardiac care. Regionalization has improved outcomes in many settings and may offer one part of the solution, but we believe in Africa, those regional referral hubs should serve as engines for capacity building and not as permanent destinations. And we believe that an African accreditation framework may provide a practical mechanism for supporting those programs and the development of that program across the continent. Next, I'd just like to say thank you to all our collaborators, participating centers, funders, and professional societies. Asanteni sana. Thank you very much. I hope I made up some time. Next.
Thank you. Thank you very much, Dr. Thomas, and for keeping to time. Unfortunately, we've run out of time for this session, so we will not be having a Q&A session. But if you meet any of our speakers, please feel free to reach out and probe them on some of these points. Please, can we also just take a minute to just clap hands for them and to say thank you for the insightful session. Thank you.
Thank you, colleagues. And again, thanks, Doc, for this. This is quite sobering. Thank you for, representing these lives here. Dr. Thomas, before you go, I like your Acacia model and we'll be probably seeing how we can discuss on this. Jean and Dr. Gupta, the Pen Plus countries, I think we talk the same language. So I think it would be easier to regionalize capacity and see how, instead of the patient moving, it's easier for the surgeon to move. I noticed that 5 out of the 8 level 4 centers are, for example, in South Africa, it's easier to have the surgeon move and we aggregate patients across different Pen Plus countries, and he comes and builds capacity in a mentorship way. So I think it's possible. If countries like Slovenia and Croatia can do it across borders, we can also do. It's just willingness of the countries. And since we have a lot of support from the WHO, the WRs are here, maybe we can see how we can do it. Start small across the Pen Plus implementing countries, have the capacity from countries that have it, see if we can move it across the different boundaries, bring patients together from different countries. Maybe once we start, the problem is just starting. But once we start, maybe it will be all right. Thank you so much, this panel. Unfortunately, time is not on our side today because we started late. So tomorrow, if you can come early, then you'll have a better time at lunch and to even have more time to socialize. So we will be breaking to the parallel sessions. Where is Terence? Yeah, that's the information we have. We have 3 sessions. The country sharing experience in Mikumi Conference Hall. We will have Lesotho, Nigeria, Malawi, Kenya, and Zambia. Let me repeat that. Mikumi, we will have Nigeria, Lesotho, Malawi, Kenya, and Zambia. To get to Mikumi, you get outside, you turn right, you will see some stairs, do some physical activity for the day. All the way up, you will see Mikumi Hall right there. The second parallel session will be the one for the French-speaking countries, so they will be in this hall because they require translation. And that will be Burkina Faso, Cameroon, Democratic Republic of the Congo, Republic of Congo, joining virtually, and Benin. Those are the 5 countries that will be in this session for parallel session 2. Dr. Sidi Mohammed will be with those colleagues here and will moderate the session. And Dr. Joseph Moga, my colleague, will be in Mikumi Hall supporting the English speaking. The final parallel session is going to be moderated by the Tanzanian Ministry of Health, and that's going to be in Ruaha Conference Hall. To get to Ruaha, get out, turn left. Behind the NCDI booth, you will see Ruaha Conference Hall. That's where you'll be meeting the MOHTZ as a parallel for MOHTZ. These sessions will continue until, now it is 1:45. We'll continue until 2:45. Is it? Yes. And then we will have our lunch. Please, those moderators, make sure that guys have 45 to 1 hour lunch to make sure that we are back in this hall again at 3:45, 3:45 for session B on breaking the silos. A very interesting session, please don't miss. So we all meet back here at 3:45. So let's move to the parallel sessions, the 3 of them. I repeat again, in Mikumi, Silas Conference Hall here, and in Ruaha Conference Hall. Thank you, and this session is adjourned. Hey, dude. I was wondering, I've not seen you. I'm like, where is this guy? Even you called me. Oh, okay, all right. Yes, you continue here. Yes, very speaking. This is Colin. Where is Colin?
Donc, bonsoir. On va continuer directement avec notre session. Pour le groupe francophone, on reste dans cette salle avec le Bénin, le Burkina Faso, le Cameroun, les deux Congos, alors, donc notre session s'inscrit dans le cadre du ICCPA 3 sur le partage d'expériences, dont l'objectif est de permettre aux pays de partager leurs progrès, les défis, les innovations, les leçons apprises dans la du PEN+. D'accord. On a le Bénin, le Burkina Faso. I did it.
Hello, I hope you can hear us. So this session will be the Francophone country exchange sharing. Therefore, Burkina Faso, Cameroon, Democratic Republic of Congo, and also Republic Congo. Actually, that is virtual participation, and Vietnam. Please remain this room. So if you are the speaker for the country presentation, please kindly come to the high table.
Yes. Donc, nous demandons aux pays suivants, le Bénin, le Burkina Faso, le Cameroun, la RDC. Est-ce que le Congo va nous rejoindre en ligne, si j'ai bien compris? Donc, ceux qui sont là peuvent venir à côté de moi pour les échanges d'expériences. Merci beaucoup. Le Bénin est déjà là. On attend le Burkina. Ah, on dirait que les deux Congos sont là. Bonjour, Judy Kael. Ça va, mon frère? Ok. Ouais, ça va. Ça va. Il reste Sibérie. Il est là, le voilà là-bas. On a pas mis. Donc, on va commencer, je pense, pour ne pas perdre du temps, parce qu'on n'a pas beaucoup de, on n'en a pas beaucoup. Donc, juste avant de, on veut se rassurer qu'il y a la traduction pour ceux qui ne parlent pas en français. Est-ce qu'il y a la traduction? Ok, donc on va essayer d'être très pragmatique. On va essayer de donner 7 à 8 minutes par pays. Parce on a réduit notre temps. On avait 1h25. Là, on nous a ramené à 1 heure. Donc, 7 à 8 minutes par pays. Soyez vraiment pragmatique. Ne soyez pas prolixe dans vos paroles. Et on va pouvoir tenir dans le temps. Donc, mesdames et messieurs, chers collègues, au nom de l'Organisation mondiale de la santé, j'ai le plaisir de vous accueillir à cette session consacrée au partage d'expériences des pays sur la mise en œuvre du PEN+, et le renforcement de la prise en charge intégrée des MNT. Cette session constitue une occasion d'apprentissage mutuel entre les pays. Elle nous permettra d'examiner les progrès réalisés, les innovations, les meilleures pratiques au niveau des pays, les défis également qui ont été rencontrés par les pays, ainsi que les solutions qui ont été développées par les pays pour améliorer l'accès aux soins de santé de qualité dans le domaine du PEN+, qui concerne les maladies non transmissibles sévères. Alors, donc, comme l'a rappelé la stratégie PEN+, aucun pays ne pourra atteindre ses objectifs liés aux maladies non transmissibles d'ici l'horizon 2030 sans renforcer simultanément les capacités des pays en ce qui concerne les soins de santé primaires, la formation, les hôpitaux, les districts et les systèmes de référence et de contre-référence. Cela n'est pas possible si les pays ne se mettent pas ensemble. Donc, nous allons écouter les 5 pays, Bénin, Burkina, Cameroun, RDC, Congo. J'espère que je n'ai rien oublié. Et je vais vraiment inviter les présentateurs à être pragmatiques, à mettre réellement l'accent sur les progrès réalisés, les approches innovantes, les défis et les leçons apprises. Et si possible aussi les priorités pour la mise à l'échelle. Alors, donc, notre premier présentateur sera le Burkina Faso. Le premier intervenant sera le docteur Kabouré Sibiri. Le Burkina fait partie des pays qui ont réalisé des avancées importantes en matière d'intégration des services MNT à travers l'extension progressive du OPEN et la préparation et la mise en œuvre du PEN+. Donc, j'ai le plaisir d'inviter le représentant du Burkina Faso à partager son expérience. Vous disposez de maximum 8 minutes. Merci.
Donc, merci. C'est un plaisir pour moi et un honneur pour moi de partager l'expérience du Burkina Faso. C'est un plaisir pour moi de partager l'expérience du Burkina Faso dans le processus d'intégration des maladies non transmissibles sévères dans la lutte contre les maladies non transmissibles en général. Et donc, j'ai préparé cette présentation avec l'appui de l'OMS pays. Et donc, diapo. Et donc, pour dire que le Burkina Faso, dans la mise en œuvre du PEN+, a suivi les orientations de l'OMS, savoir la mobilisation des ressources, et la mise en place des stratégies et des plans et des directives, et le renforcement des compétences. Diapo. Donc, en termes de situation de contexte général, il faut dire que le Burkina Faso est un pays enclavé au cœur de l'Afrique occidentale. C'est un pays qui compte environ 24 millions d'habitants, avec divisé en 13 régions sanitaires, 70 districts sur un territoire de 274 000 km². Et donc, le dispositif du PEN Plus a été intégré dans le système organisé de soins, ce qui permet en tout cas, facilite l'ancrage opérationnel du modèle au niveau intermédiaire. Diapo.
Intermediate level. Next slide. So the 2 districts were selected as pilots, and the NCD model was defined in collaboration with the various stakeholders. You had Buse district, which is in the Central Plateau region, and then as well as Kupela in the Center East region. Next slide, please. So that was just a reminder on the NCD burden, which is 35% of the total mortality and 24% premature birth risks, and then you have 52,800 annual deaths from NCDs, and these are drawn from WHO sources. So the premature death prevalence will remain, will stabilize if nothing is done. So just to note that there are people having some challenges with their interpretation sets. So if it's not working, please reach out to, please just switch off and switch on, change the channel, and you'll be able to have the interpreters. Otherwise, there is English interpretation. Please, for those who need to follow up in English. Thank you. Next slide, please. So there is a sobering progression of diabetes in Burkina Faso. It has multiplied by 4 with a prevalence that has stagnated from hypertension, and there is a risk. It is now a major public health risk. Next slide. As to the common risk factors from SCDs, I would like to note that the behavioral and metabolic risks call for integrated care, and the health district is the starting point to bring down complications related or arising from NCDs. Next slide. As to partnerships, NCDs, and the control of severe NCDs is something we'd like to note that our country is receiving support, especially from the NCDI and Poverty Network. They are the main partner supporting the government of Burkina Faso in rolling out the PEN Plus strategy. Next slide. Burkina Faso has carried out a number of activities, and we came up with an operational work plan on severe NCDs, which is aligned with our in-country NCD roadmap, and we came up with an annual work plan, and that is broken down into modules, protocols, and algorithms that are used by the service providers, and the PEN Plus strategy is properly aligned in the integrated healthcare plan to control NCDs. Next slide. So that's an overview of the various strategic documents that we've developed. So we have diabetes type 1, sickle cells, hypertension, and congenital heart disease. And we came up with protocols and modules and algorithms to provide healthcare to those suffering from all of these illnesses in the district hospitals. Next slide. And in Burkina Faso, PEN Plus is a package, information meetings, briefings for all of the stakeholders, especially at the managerial level, the district doctors and training of trainers. And you have for training for general practitioners and other stakeholders. And you have about, you have training that has been provided to 75 stakeholders to implement this PEN Plus strategy. Next slide. And as I earlier indicated, we have briefings, you have training of trainers, information sessions. Next slide. And this helps us to provide healthcare on the ground to persons suffering from these diseases. And our country received support from partners and to purchase equipment and deliver them to these facilities. We also have devices for echography, heart echography, as well as other devices that are being used to implement this strategy. Next slide. And there we have the KPIs presented by the various speakers earlier. We are convinced that we have key KPIs for severe NCDs, and this has been incorporated to allow for proper monitoring and evaluation, and to also assess performance as determined by the ministry. We have quarterly, half-yearly meetings and midterm reviews. Next slide. And since we started implementing this strategy, from, we must note that in 2026, we recorded 500 persons from sickle cell, and then you also have 3,400 persons from hypertension in the sites, the two pilot sites, the two district hospitals, that is Bosi and Kupela. Next slide. As to the sites that are implementing these, you have Bosi and Kupela, and we are being supported by NCDI and WHO. And we have come up with 6 priority clinical areas. You have type 1 diabetes that is covered, as well as sickle cell disease, and then rheumatic heart disease and severe hypertension. And we came up with a package of treatment measures to be taken in collaboration with the learned societies and those on hematology, endocrinology, and the Learned Society of Cardiologists of Burkina Faso. And there you have the registration of patients, as you can see on the graph. Next slide. Those are still figures dealing with registration of patients as well. Now, this brings us to the challenges and mitigating measures, the solutions to the challenges. So the coordinating team will have to form the PEN Plus committee that will be responsible for monitoring and evaluation. You also have to reinforce or strengthen the information system by coming up with clearer KPIs, and also engage in resource mobilization, and also expand to other district hospitals, making sure that we also expand the package to other NCDs like cancer, eye diseases, and so forth. Next slide. Those are priorities for next year, 2027. So monitoring, mentorship, training, and expanding the network. Next slide. So those are images of activities on the field during training sessions. So that is training of trainers, first of all, and then we also have training of district hospital health workers. Next slide. So that's a final image and the group photograph of the meeting we had with the training of trainers, and then the training of the district hospital health workers, and we provided support from NCDI, and the NCDI representative is there on the picture. And this brings me to the end of my presentation. Thank you. Thank you so much to Dr. Kabore Sibiri for this very informative presentation, presenting the main activities carried out in Burkina Faso, as well as the commitment from the Ministry of Health to incorporate NCDs and also coordinate 10+ activities. We also noted that the country has come up with a number of repositories and also pilot facilities, and where this strategy is being carried out, and also providing capacity building to service providers, as well as other measures taken to ensure that there is proper equipment, also clear KPIs, and we also have the challenges and the priorities that were highlighted. Thank you to Dr. Kabore and Burkina Faso. Our next speaker will be Cameroon, and that's Dr. Vaisaba Emmanuel. Cameroon has a wealth of experience in organizing NCD activities, as well as incorporating healthcare for several priority health diseases. So it's my pleasure to call up Dr. Vaisaba to present Cameroon's report. Thank you. Thank you for giving the floor to Cameroon to share Cameroon's experience in 10+ implementation. Next slide. So that's just by way of background. We have a population of roughly 30 million inhabitants, and with 10 health regions and broken down into 210 health districts. We have roughly 170 district hospitals, these are government hospitals. And we have the 10+ in 2 health districts. These are like pilots, one in the central region, which is a semi-urban region, and the second is in the south region that borders Congo and Gabon. So in terms of the burden of NCDs, according to the report presented by the experts in 2022, NCDs account for roughly 35% of the of deaths globally. And then you have injuries that account for 10%. So this gives roughly 43% that account for deaths due to NCDs. Next slide, please. So I would like to note that after the first 10+ conference held in Tanzania in 2024, that was in April, Cameroon held the first meeting that brought together stakeholders in September. That was 11th, and we had roughly 170 participants from various sectors, civil society and partners, as well as the other ministries. And this was to launch the 10+ strategy in our country. Next slide. This was followed by other activities. So following this launch, a team was formed to coordinate PEN Plus activities, and we came up with the strategic plan, the operational plan for implementation, and we also came up with care protocols and guidelines targeting 4 illnesses, that is type 1 and diabetes, sickle cell, rheumatic heart disease, and asthma. Next slide, please. And we had 2 training sessions, that is on-site and training on the 2 sites. Each session lasted 13 days. And we, for each of the illnesses, we had specialists to deliver the training. And they trained 3 general practitioners, 10 nurses, and you also had data teams. So on both sides, we trained roughly 17 persons, and on the various modules for the 4 identified diseases. Next slide, please. So for the partners that are supporting us, we have WHO, the country office, that is providing support in planning and providing technical support and training and oversight on the sites. We also have another partner, that is Helmsley, that has been supporting us since 2022 in developing the situational analysis, the SWOT analysis, and also gave us the possibility to come up with training tools as well as models. We also have the Clinton Health Access Initiative that is supporting more in terms of coordination meetings. We hold our regular coordination meetings and also review monthly data. And they will be supporting us in the midterm analysis and evaluation of the strategy. And then we also have the PFRAB Foundation, and that is supporting us in one of the clinics, screening for sickle cell, neonatal sickle cell screening. Next slide. There, those are photos. And that was during the launching ceremony in the 2 clinics. And the official launch took place on 17th December. And this was presided over by the Permanent Secretary of the Ministry of Health in the presence of the WHO country representative. So you have a stock of medicines and other resources that were donated during the launching ceremony. Next slide. So as to the progress status, broadly speaking, we would like to note, as I earlier indicated, that we've come up with a protocol, and we also incorporated activities. So PEN Plus activities were incorporated into our operational plan for the country. Unfortunately, we don't have a training program as it stands, because the first service providers were trained directly by the specialists. So we've not yet formed a team that will continue to train the other service providers. So this is something we still need to work on. And we are also having challenges with the availability of certain medicines like hydroxyurea and insulin in the clinics that we are using to pilot this project. Next slide. As I was noted, since we are being supported by the PFRAB Foundation, we are screening for sickle cells, and since January, we've screened about 174 children. This is free screening. So we screen all the newborns in this health facility. It's a systematic screening. And we have about 174 that have been screened. And we've already identified 14 sickle cell cases. So the overall situation of the disease per illness. So between January 2026 and May, we have 130 that are being monitored in these clinics, and each month we do an assessment with the support from the CHI, that is Clinton Health Access Initiative. Next slide, please. So this is just a graph on the progress. So we started with 18, and each month we've been gaining momentum, and you can see the increase. And the main challenge is that in Cameroon, we are not providing free care. So we have strengthened the capacity of the patients, and they should be able to pay at the usual rates. And since it's not free of charge, we have not yet elicited the enthusiasm that we need. So we are growing steadily, and we are also raising awareness. We have not yet done this optimally, so we need to also step up awareness raising for the beneficiaries to understand why they need this and why they need to go to the Pen Plus clinics regularly. Next slide. And those are some KPIs that we use. So we have the WHO KPIs to assess care provided for these diseases. You can see that a lot of red because we are having challenges with the availability of inputs and the cost of inputs. And so all of the patients who should be receiving healthcare and be having the devices to test your sugar levels and everything, they don't yet have these devices to be able to conduct the tests. So there is a gap to be filled for us to improve on our KPIs. Can you move faster, please? So next slide. In terms of challenges, we are having a financing gap. We've been receiving support from WHO, and this was for the pilot phase. And we did what we could, but as it stands, with the support from the other partners, we will need to step up our game, and this will call for resources for us to fill the gaps. We also have stockouts of supplies in these health facilities, especially insulin and hydroxyurea, that we don't have a steady supply in these health facilities. We also have the high costs of medicines because most of these drugs, specialized drugs, they are not generics. So it's usually a challenge to make them available to each patient. And we also have the issue of awareness campaigns to ensure that the patients go to the Pen Plus clinics to receive care. So we will need to go on the field, not just to raise awareness, but also screen and the patients for sickle cells, the type 1 diabetes, all of the identified diseases. We need to go to the field and strengthen our action. So our priorities for 2027, we need to provide mentorship because these service providers need to be mentored. We are going to step up this activity. We also need to improve coordination, also facilitate the drug supply chain. And if the means permitting, we need to extend the strategy to the other districts or regions. Next slide. This brings us to the key messages and advocacy. I would like to note the need for government leadership, and this actually facilitated the support we provided to the other partners, and the government facilitated this site for us to enjoy partnership, receive partnership. We have some patients who received care because going for more than 300 kilometers to the city to receive care is a problem. So by bringing the clinics closer to the people, this address the logistics problem. And these health facilities are now there, and the Pen Plus strategy also facilitated the provision of universal health care in our country. And it is our thinking that we need to step up multi-sector collaboration for resource mobilization and also extend the strategy to the other districts in the country. And so we need the mobilization of local resources. And with this brings me to the end of my presentation. Thank you for your kind attention. Thank you for sharing this very informative experience from Cameroon. That is 36% of NCDs, and also the fact that mechanisms are in place with support from all the partners. And we've had a PEN Plus strategy piloted in 2 health districts. 13-day training sessions were organized. We have support from several partners, and WHO, ACT, PFRAP Foundation, the Clinton Health Access Initiative. There were challenges related to human resources, drug availability, financing gap, but there is solid leadership from the government that is also making efforts to provide universal health care and also mobilize local resources. Thank you to Cameroon. We are going to proceed with the next presentation. That will be by Dr. Muchara Amuru from the DRC. So this is a large country with several different health contexts, and so the DRC is a very important country that will be giving us very useful lessons as concerns scaling up PEN Plus as well as other interventions. So I would like to call up the DRC to present its experience.
Gamuri. I'm an expert in non-communicable diseases. I work in the Ministry of Public Health and Social Protection. I want to share with you our situation in the DRC. Let me begin with the background and share with you our epidemiological profile. I want to also share some of the activities that we've already implemented with support from different partners. I will then look at our next steps that we anticipate and share with you the challenges to end. So for the Democratic Republic of the Congo, then, it's a vast country with about 515 health districts. We call these district zones. We have 515. Our population is more than 100 million inhabitants. We have numerous epidemics that we address. I've shared with you just a few on the screen that are currently being addressed in our country. We have cholera, and you can see the number of cases, deaths, and case fatality rate, the number of cases for measles. In 2025, we also, in 2025, had an mpox epidemic to deal with. But I want to look at the Ebola virus disease. EBD is currently active in our country. The WHO gave some statistics right up to yesterday. This is a danger not just for our country, but the entire African region and the world altogether. This is the 17th Ebola virus disease outbreak in our country in 3 provinces in our country: North Kivu, South Kivu, and Ituri regions. We have about 34 health zones, I beg your pardon, which are affected by EBD. We have had more than 300 deaths that have been reported. These are statistics from 2 or 3 days ago, but of course by today, statistics will already have changed. So the next slide. For NCDs, in 2025, we carried out a stepwise survey in 3 provinces in Kinshasa, Achopo, and the Kasai, Eastern Kasai district. And just to share with you some data from this survey. For the positive test for cotinine, we had 20% amongst men. We had hypocholestemia, 3.5% amongst women, 2.5% for the men. For obesity, we had 16%, or rather 17% for women and 5% for men. For overweight, we had 25% for the men and 35% for men. For hypertension, we had 30% for women and 26% for the men. For diabetes, 7% amongst women. Oh, it looks like we have some challenges with the data for the men. It's still to be filled in. We wanted to show the mapping of some of the partners working with us. We have WHO and SLA through WHO as well. With their support, we've been able to carry out numerous activities. Let me give a little detail on this in a moment, but I'd also like to say that the government has supported us. We're currently negotiating with the World Bank so as to garner support for 9 districts in our country. Can we have the next slide, please? Okay, so here you can see where we are now. We in phase 3. We had 3 pilot surveys in 2 cities in Lubumbashi and Kinshasa. So following these 2 pilots surveys, our next phase is monitoring and evaluation, which is for the 2026 period. The next slide. You can see here that we had support from WHO and we've carried out several activities to date. In particular, we've drafted the national strategy, the multi-sectoral strategy that is for combating NCDs. We've also been able to draw up specific strategic plans for diabetes, cardiovascular diseases, and trypanosomiasis. So we are focusing on these 3 diseases right now. Support we've received has also enabled us to adapt the 10+ guidelines and also the protocols. For example, the protocol for the NCDI network to fight poverty. We've been adapting these guidelines to the DRC situation. We've also been able to carry out 2 pilot surveys in Lubumbashi and Kinshasa, as I said. What I'd like to highlight here is that the support we've received has enabled us to organize a large advocacy meeting at a high level with the support of the Ministry of Health, Hygiene and Prevention. Now, following this meeting, or thanks to this meeting, we've been able to mobilize additional resources for further establishing the 10+ strategy in our country. Here I have some data to share on the 2 pilot sites for the patients. I can't really see the details on the screen, but we have about 992 cases. That is a cohort that we're working with. This is as to trypanosomiasis, hepatitis type 1 and 2, and BP. We've also trained 54 service providers. Next slide. This is to do with our next steps now. So with the support of the ADB, we are currently negotiating to scale up in 9 provinces. So in these 9 provinces, we will be working to extend PEN Plus in about 900 district hospitals and health district centers to provide training, to improve services, to provide equipment and medicines, but also to carry out mentoring activities. We are currently in negotiations. We have drawn up our concept note. However, with the current situation in our country, and here I speak of Ebola virus disease, this is taking up most people's attention, so we need to wait before we can continue with our activities. With the support of WHO, we've carried out high-level advocacy. I mentioned this already, and this has helped us to mobilize funds from the World Bank, and this has brought, we've been able to bring together all the different players working with NCDs, and this was thanks to advocacy activities of the Minister of Health, which led to the World Bank funding. We've been working to ensure that we integrate NCDs in the Universal Health Coverage package. Next slide. Now to look at our major challenges. So despite our 2 pilot activities, we can still find the situation prevailing of insufficient equipment in the health centers. NCD indicators are not well implemented. We've had challenges as far as data collection with the District Health Information Survey 2. Our major challenge is the resurgence of EVD. I was saying that all the donors are now focusing on Ebola. And so the support we were receiving has dwindled somewhat because of the Ebola virus disease. We need co-funding to boost the PEN Plus strategy. Our government is fully committed, as well as WHO and the NCDI network, the World Bank. So this gives us a certain amount of hope as far as further implementing the PEN Plus strategy in our country. To share our lessons, what we've learned, well, at the high-level meeting I mentioned, we learned a great deal. We understood that if the strategy is supported by our national authorities, this will ensure that we have positive results as far as resource mobilization. Another challenge is that there is poor access to screening services and prevention services as far as the risk factors for NCDs. The major challenge, however, for our country is the insecurity that exists throughout the eastern part of the country. There are some provinces like Ituri and Northern Kivu which were targeted for support from the World Bank programs, but we are unable to deploy in these insecure areas. So the next slide brings us to a conclusion. Thank you very much for your attention.
Merci.
Thank you so much to the DRC for sharing their experience. Even in very challenging environments, we can still make progress thanks to leadership and support of partners that you highlighted. In especially you're looking at your partnership with the World Bank, which for the next steps will help you to scale up 10 plus in your country. So congratulations to you. Let's continue. We would like to hear from the Republic of Congo, Dr. Pasi. The Republic of Congo has been implementing numerous initiatives for NCDs and strengthening their health system. Dr. Pasi, you have the floor to share with us your experience in Congo, Brazzaville. Let me just remind you that we are a little late for lunch, and so we have about 15 minutes remaining. So over to you. Okay, thank you very much. I will be as succinct as possible in my presentation. I'm Dr. Pasi. I am the lead consultant at the WHO country office in the Republic of Congo, working for the implementation of 10 plus in the country. Let me share with you Congo's experience as far as implementation of the 10 plus program. The Congo is the Central African region. We are about 302 square kilometers, and our population is over 6 million. We are surrounded by a certain number of countries: Angola, DRC. As you can see on our map, you can see our neighboring countries. We have been working with the reference hospitals, the general hospitals, and the central region. So we have the three levels of health care provision. So as far as a profile for NCDs, we have had numerous epidemics. We do have the epidemiology that we have highlighted. 35% of deaths have been registered, mostly by cardiovascular diseases. Hospital data highlights that we do have a trypanosomiasis, which is about 25%. As far as the intervention strategy for the 10 plus, we work at the health centers. The strategy has been implemented since 2023. In 2024, you can see that more health centers are implementing. We have 95% of our health centers having been strengthened and have received training. We have 75 health workers who have been trained and who receive support and screening equipment for diabetes and for implementing the different case management protocols. So since 2024, the PEN Plus strategy has been implemented at the district hospital level. Next slide. So to share with you what we've been able to do since October 2024 to June 2026, we set up a technical working group within the Ministry of Health. We drew up a plan. We have 3 health districts colored in red on the map for our pilot. In the north, in the southeast, Majipukai and Majingu. The ministry has carried out an analysis of the severe NCDs in the region and agreed on a health package to address trypanosomiasis and BP. In November 2024, we had the official launch of the Pen Plus program in October 2024 with numerous partners in attendance. We are looking at BP and Triple as the major focus. We have recently validated our document on case management. We have adapted the guidelines in our health district. We worked on this guide in December 2024. We have a simplified guideline for trypanosomiasis and for NCDs in the first level health centers. Next slide. We have crafted communication materials for disseminating information, and we have also guidelines on data collection for NCDs in general, but for the Pen Plus. We have numerous documents that we drew up in December 2025 based on the data collection activities we carried out. So by June 2026, from October 2024, we have carried out training activities. We've trained health workers, nurses, health district managers, as well as doctors and administrative staff in terms of dealing with diabetes at trypanosomiasis. We've carried out activities and drawn up different documents for this purpose within the Ministry of Health. Next slide. We have implemented severe NCD management at the Doma Kelekele District Hospital in Brazil, and we had activities from the 5th to the 6th of June. We identified a case a few days following. You have a picture there for the diabetes and trypanosomiasis. As far as the key indicators for monitoring the program, we've not yet implemented all the indicators in the DHS2 system, but these are the indicators we are working with currently. From the 7th of the 20th of June, we had 4 patients for trypanosomiasis whose cases are being managed. The significant challenges for implementing the strategy is the lack of adequate resource mobilization activities at local level. We need partners. So to date, we have been receiving funding from the World Health Organization through the MSLEEP Trust. There is limited availability of medications, equipment, and staff, or everyone has mentioned this already. For the next slide. For 2026 and 2027, we want to carry out mentoring activities to supervise activities at the health centers as far as Pen Plus. Scaling up, we need to strengthen advocacy for district level implementation of Pen Plus. In Brazzaville, we have a pilot health districts where we launched the Pen Plus strategy in Kelly. However, we plan to deploy in the 3 district zones. We have had some lessons that we've learned for NCD case management to date. for chronic asthma and cardiovascular diseases. I would like to highlight that the Pen Plus implementation is an opportunity for our country to strengthen the combating NCDs and severe NCDs in the country, and to ensure support from partners at local level as well as support from foreign partners, so that we can carry out additional mobilization for human, material, and financial resources, so as to accelerate scaling up of the Pen Plus strategy in our country. We'd like to thank AFRO and MPLAY for their support to date, and I will end here by thanking you for your attention. Thank you very much. I share in your conclusions. Let me give the floor to Benin to help us to move forward for our program. It is Dr. Salman who is presenting. Salman Midu. Benin is fully committed in developing the Pen Plus strategy, in drafting normative tools, and also it is a pilot country in the WHO Pen strategy. So I invite you, Dr. Amidou Saman, to make a presentation. Thank you so much. You have taken some time to introduce me, but in any case, thank you very much for the conclusion, or rather the summary of our work in Benin. I wanted to share with you the little that we've done to date. We can move to the next slide. I need some help with the slides. Next slide, please. It looks like these are not actually my slides for Benin. It looks like there was some confusion with the slides for Benin. This is not my presentation. Let me try and summarize my presentation. We've working for a long time in NCDs. We were in 2008 one of the first countries that had NCD programs in place. We had the WHO PEN from 2008. We one of the few countries that have covered the entire national territory in 2024 for WHO PEN Plus. We've been looking at the specific phases as far as the NCDI network. The initial phase was to set up an NCDI network in the country to carry out the situation analysis, and from there identify the severe NCDs, which are our priorities. The specific nature of Benin, it's different from other countries because most of the other countries chose type 1 diabetes and trypanosomiasis, and it's rather cardiovascular diseases. It's cerebral, type 1, and strokes are the ones that we've been focusing on. We have been working to start out Pen Plus by, first of all, identifying protocols. The protocols were we worked with the existing services. We have 4 clinics that have been working on trypanosomiasis, so we used their protocols. They have been working with about 6,000 patients to date. we went to about 10 different hospitals that provide care for diabetes to implement our protocols. And then we now looked at how best to implement Pen Plus with those health centers already working in the sector. We finished our work as far as identifying spaces dedicated to Pen Plus. We are going to start with training of trainers in the third week of July. I have work with NCDI network in a few moments on that. In the last quarter of this year, we will be launching 4 Pen Plus pilots sites. One of the successes in Benin, which I'd like to share, is that for the past 3 years, in June, we've chosen June rather as the month dedicated to trypanosomiasis in the country. It's to deal with blood diseases, focus on them in the month of June. We have numerous activities to raise awareness and to advocate that at community level we can deal with sickle cell in the country. So this is our month for our activities. This week we'll be carrying out screening to screen about 30,000 people in a short period of time. So just a summary. Thank you very much. Thank you very much, and congratulations to Benin for the work that you've been carrying out. We've understood that we actually need to leave the room. So let me congratulate all the countries. Thank you to the presenters for the quality of your presentation. Thank you for sharing with us your experience to date. You've all had different experiences, but you have stuck to the common themes. We have seen this coming out in all the presentations. The themes are the need for primary health care capacity building. Everyone has highlighted this. There's also the issue of availability of medicines and technology, which is essential for all countries. And this is recommended for the pilot phase and also for the scaling up. More resources are required. There's also the capacity building for human resources and greater mobilization of funding. These are the main issues that all countries addressed. I'm certain that for the next steps, we will be able to address these issues, especially as we build on the mentoring that you've all mentioned, as well as taking advantage of the leadership from the Ministry of Health. Our resources, of course, need to be mobilized locally. Partner funding is limited, so mobilization of resources needs to be carried out at national level to address the needs of scaling up Pen Plus. We've seen this for WHO Pen, so now you would need to do the same for Pen Plus. We will not have a question and answer session in this session, unfortunately. We would rather encourage you now to move to the lunchroom where others are already. So 4 p.m. we will be back in plenary here for the next session. Thank you very much for your understanding. Please applaud all the presenters. Thank you very much.
Chers participants, le retour est dans la...
So just to highlight that we should need to be back here at 15:45 following lunch. Please be back by 15:45. Thank you very much.
calling me yet. Yeah, so good afternoon. Unfortunately for you, you have me again on the podium.
Boa tarde, infelizmente.
Session 4, Breaking Silos, Opportunities for Integration. We'll give it about 5 minutes because the room is quite empty to make sure that other people join us and we can start our session. In the meantime, I'll just want to make sure that all my presenters are here. John Sentamu, you're here? Okay. Alvin Mutengere. Alvin, you're here, yeah. And I've seen Raul, you're around. Mugabe Frank. Good. So in 5 minutes, we'll start our session. Thank you. All right, so can I have all your attention? We're about to start our session. Hello, colleagues at the back. Can I call on the podium the following presenters? Dr. John Sentam, can you please join the podium? Dr. Alvan Mutengere, Karibu. Dr. Raul Ramejo, and Dr. Mugabe Frank. Please approach the podium and take a seat here. So as indicated in our program, our session is focusing on breaking silos and for us to delve and look at opportunities for integration. We've heard since morning, starting with our presentation this morning and the UNICEF meeting that the parallel session that we had, and we talked in detail about interventions, having integrated NCD services. Traditionally, as we know, most of our healthcare services have been delivered vertically, and they've been disease-specific programs. And through this, we've missed several opportunities to provide patient-centered care. So this session will focus on the practical experience of how different countries have managed to integrate NCD, specifically PEN Plus services in their child health, HIV, maternal, community health systems, and how they've managed the referral networks, health information systems, and how they're managing also financing for NCDs. So this session will provide the practical experience, and to start this off, I would like to introduce welcome our first presenter, Dr. John Sentamu from Liberia. I would urge you to take 10 minutes for your presentations so that we have ample time to discuss in the end. So you're most welcome. Kindly briefly introduce yourself when you reach the podium.
First slide, please. Thanks, Dr. Mary, for the introduction. I'll walk you through why health system integration is essential for effective PEN Plus case finding and referral, drawing on our experience from Maryland County. Next slide. Maryland County is one of Liberia's 15 counties implementing the PEN Plus strategy with the support from the government of Liberia, Partners in Health Liberia, and the NCDI Poverty Network. I will begin with the background and the why for health system integration in PEN Plus implementation before walking you through our integrated model, community health program, which will then be followed by specific Pen Plus case finding strategies. I'll briefly touch the role of master trainers, digital health systems, peer educators in integrated model, and end up with the way forward plus 3 key messages. Let's begin with the background. Next slide. Severe NCDs in sub-Saharan Africa often remain undiagnosed or are diagnosed late, leading to premature morbidity and mortality. In Liberia, NCDs account for 38% of the disease burden and 43% of all deaths. Addressing this diagnosis and morbidity and mortality challenge requires an integrated health system that links communities, primary healthcare facilities, and specialized services. Let me now explain why health system integration is essential for successful Pen Plus implementation. Next slide. Pen Plus patients usually enter the health system for care through multiple service points. At every entry point, early identification is key to prevent the morbidity and mortality associated with the delayed diagnosis. Health system integration strengthens timely referral, continuity of care, and ensures efficient use of our limited healthcare workforce plus resources, and it ultimately improves patient outcomes. I will now share how we operationalize this integrated approach in Maryland County. Next slide. We implemented an integrated Pen Plus model linking the community, primary healthcare facilities, specialized services, and digital health systems into one continuum of care. Patients are identified in the community by trained community health providers using standardized protocols. They are first assessed at primary care facilities and accompanied to the Pen Plus clinics for further assessments and enrollment. The model is also interlinked with the TB and HIV program plus the mental health services with community follow-ups to support adherence and to prevent loss to follow-up. The foundation of this integrated model is our community health program, which derives from the Liberia National Community Health Program, and I will discuss that next. Next slide. The Liberia Community Health Program comprises 2 complementary community health worker cadres: the community health assistants, who serve the 29% of the population living more than 5 kilometers from the health facilities, and the community health providers, who serve the remaining 71% living within the 5 kilometers. Together, these cadres provide nationwide community coverage. We leveraged this existing national platform to extend Pen Plus services into the communities. Let me now show how this community health workforce was adapted to strengthen case finding and referral pathways for Pen Plus. Next slide. We established a structured community-based screening, referral, and patient accompaniment model. CHPs and GHAs are trained to recognize individuals with suspected severe NCDs using standardized protocols within the communities, and they then link them to care. And in order for us to sustain this model, digital systems are usually essential, and this brings me to our electronic health records plus M&E systems. Next slide. We implemented an integrated electronic health system and digital system across the Pen Plus platform. The system captures patient enrollments, it tracks clinical indicators, e.g. HbA1c, supports appointment scheduling, and documents medication history. That platform is also able to give us routine monthly and quarterly reports. So apart from those community initiatives, we also developed other innovative strategies to identify Pen Plus patients within health facilities, apart from the ones in the communities. I will now describe our in-facility case finding pathways. Next slide. So exemplifying with the J.J. Dawson Hospital Pen Plus facility finding pathway, every department has healthcare workers that are trained in Pen Plus. They are able to identify patients and refer them to the Pen Plus clinic using designated forms, which are referral forms. Next slide. I will now highlight the disease-specific case finding strategies that we are using, and I will start with the sickle cell disease. Our case finding strategy for sickle cell disease combines 3 complementary approaches. newborn screening of sickle cell disease, family-centered cascade screening, and diagnostic testing. When the newborn is missed at birth, we have integrated that into the expanded program of immunization, especially for those who are born outside the hospital, and we are still able to test them at the EPI services. When one child is diagnosed, our work doesn't stop there. We immediately extend the screening to the rest of the family. Next slide. So using the family-centered cascade screening, we systematically screen biological relatives of every newly diagnosed patient. This allows us to identify additional affected family members early and also link them to care. And to evaluate whether this is worthwhile, we piloted it in mainland. Next slide. In this pilot, we screened 50 biological relatives of index cases and identified 2 previously undiagnosed individuals with sickle cell disease, giving a prevalence of 4%. This demonstrated that family-centered cascade screening is actually feasible and effective in resource-limited settings. Now, when you combine it with other screening approaches, the impact becomes even bigger. Next slide. So looking at combining all these innovations over a 2 months period, newborn screening and family-centered cascade screening, you can clearly see that they identified slightly more sickle cell disease cases than the routine diagnostic testing alone. And regardless of how the patient enters the system, the standardized sickle cell disease diagnostic testing can also be used timely to identify those patients. Next slide. So we have adapted the standardized cross-site NCDI poverty network diagnostic protocol to screen individuals younger than 35 years with recurrent anemia and hemoglobin less than 8.5 grams per deciliter. And this ensures that all high-risk patients who are consistent with the sickle cell disease are usually identified. These protocols are supported by reliable point-of-care diagnostic tests, as has been discussed this morning. Next slide. So our preferred diagnostic tests are the sickle scan and the hemotype SC. Those are the ones that we use in Maryland County. So having discussed sickle cell, I now want to move to our approach for type 1 diabetes. Next slide. So for type 1 diabetes, we use the NCDI poverty network cross-site PEN plus working diagnosis, which we have incorporated into the national guideline, and this provides health workers with a standardized approach to early recognition. And in implementing this, all the frontline healthcare workers are usually aware of this tool and they are able to identify the cases. Let's now move to type 1 diabetes. Next slide. So for type 1 diabetes, we strengthen case finding through protocol-driven symptom screening and routine blood glucose testing for all pediatric patients presenting to the health facility. Again, you will see that we also have peer support mechanisms that help us with type 1 diabetes. So this facility-based approach is usually reinforced through healthcare workforce training and community engagements. Next slide. So all healthcare workers receive basic orientation training on PEN+, and we also leverage the community health program, local radio programs to improve community awareness, and that ensures that the community has early health-seeking behaviors. Next slide. So that same integrated model has informed our rheumatic heart disease case finding strategies. And for rheumatic heart disease, decentralizing ECHO to district hospitals and training mid-level healthcare workers using the NCDI poverty network cross-site heart failure protocol has been really key. Maryland County has strengthened this model through additional support systems. Next slide. So our program is supported by ongoing telemedicine, ongoing mentorships, co-collaborations with visiting on-site and cross-site cardiologists, and we have available diagnostic portable machines to improve point-of-care diagnosis. Next slide. So the PEN Plus master trainers also have a role in this. And the Pen Plus master trainers, it builds local capacity to sustain high quality rheumatic heart disease case finding. And here is an example of how this program has performed in our setting. So you can clearly see that when they are enrolled into training, they continue with mentorships and they continue finding cases in the different aspects of the ward. Next slide. So in our own setting, we trained 6 master trainers in focused echocardiography and rheumatic heart disease case finding. And during the program, 150 individuals were screened. 3 new rheumatic heart disease cases were identified with an overall prevalence of 2%. And we are also aware that that training also requires extensive supervised practice. Next slide. So with that training, we also reached out to schools for echocardiograph screening in schools, but that was mainly meant to perfect the skills of the master trainers at a nearby school. Next slide. Okay. I want to mention that on its own, for finding cases alone, that does not improve outcomes for Pen Plus cases. Patients must successfully navigate referral pathways, initiate treatment, and remain engaged in care. This is where an integrated health system becomes very important. One other important component of that system is peer support. Next slide. Now, peer educators strengthen case finding by increasing community awareness. They encourage they support referrals, and they also help patients remain engaged in care. This is our peer support system. That's how it's organized in Maryland. Next slide. Our program currently has 8 peer supporters, 6 for type 1 diabetes and 2 for sickle cell disease. And again, for that to be effective, again, we have digital health solutions that strengthen all those connections. Next slide. So for the digital health solutions, we have virtual NCDI poverty network, case reviews, conferences, telemedicines, and at the same time, we are able to ensure that all patients that are picked within the community health care workers enter them into the digital health systems, and we are able to pick that at the center. So as I come towards the end, next slide. The future of Pen Plus actually lies in fully integrated health systems that connect communities, primary health diagnosis specialist services, and digital health systems. Next slide. So we actually need to think of closing the gap. As we strengthen the Pen Plus clinics, we must equally strengthen the links back to the communities. And these experiences actually lead us to 3 main takeaway messages. Next slide. Next slide. So the takeaway messages, based on our experiences from Maryland, our experiences in Maryland have demonstrated that successful Pen Plus implementation requires more than the usual Pen Plus clinic system that we have envisaged. It requires integrated case finding, strong referral systems, trained healthcare workforce, super trained mid-level healthcare work and clinicians, master training, empowering communities, digital health solutions, peer support mechanisms, and above all, sustained government leadership. Next slide. I want to say thank you. Next slide. And I would like to acknowledge the government of Liberia, the Ministry of Health, the Maryland County Health Team, and all our Pen Plus facilities, and the WHO country office, plus the NCDI poverty network. I thank you.
Thank you, Dr. Santamo. And I was going to say a big round of applause, but you already got that. So I think they were all impressed with this presentation. The one thing that I've learned from your presentation, if I could pick one, is we have to find, sometimes we have cases in our hospitals, Pen Plus cases, and we miss them. So as much as we think of screening and identifying cases in the community, we also need to look in our hospital wards, we need to look at our clinics, and that sets the stage for our next presenter, Dr. Alvin Mutengere from Zimbabwe, who is going to talk about synergies of PEN and PEN Plus for comprehensive primary care. You're welcome.
Thank you so much, Dr. Mary. Yes. So today I am going to talk to you about some practical experiences on the synergies of PEN and PEN Plus. So one of these things is that these two initiatives, they are not coming to separate one another, but they are coming in to complement one another. I'm going to share with you a practical experience from what we learned in one province of Zimbabwe, which is called Masvingo. Next slide. So as we know, NCDs, they are a family of more than 200 conditions. So we have lots of NCD conditions. Type 2 diabetes, which is type 1, type 2 hypertension, rheumatic heart disease, heart failure, and the list goes on. So we have lots of NCDs, more than 200 conditions if you are to quantify. No, sorry. Go back to this. Yeah. So in order for us to tackle the management and programming of these NCDs, we need to come up with some form of integration, which is something that can cluster certain conditions together so that patients can be able to receive the amount of care that they need from trained healthcare providers and in different settings. So this means that we need multiple integration tools and integration models. And so in terms of NCDs, examples of these integration models are the PEN Plus, which is a model which clusters NCDs of childhood onset. We have the PEN, which is a model which clusters NCDs of adult onset. We have the cancers, and within the cancers, they can also be clustered as childhood cancers and also adulthood cancers, and then mental health. But for the purposes of this discussion, we are just going to dwell more on the PEN and PEN Plus. Next slide. So PEN and PEN Plus are two things which serves different needs. But however, these are things which can coexist together. With PEN, we are talking of uncomplicated NCDs, usually of adult onset. And these are NCDs that can be easily managed at primary healthcare facilities because most of the consultations, they are just drug refills. And these consultations also for PEN, they are short because, like I said, it's usually drug refills and minimal patient consultation. Now, PEN Plus, we are looking at severe NCDs, childhood onset. These conditions are best managed at first level hospitals because there is a specialized form of care that is imparted to middle level care providers. Because there are severe NCDs, it means that the consultation time is also slightly longer than the PEN. And examples of PEN, we have type 2, usually we have type 2 diabetes, that's what we usually talk about in hypertension, whilst PEN Plus, we talk of type 1 diabetes, sickle cell, rheumatic heart disease, congenital, and the other. Next slide. So for our example, in Masvingo, which I highlighted, sorry, previous slide. Okay, maybe there is a slide which is not showing, but that slide, it's mainly showing the timelines of how PEN and PEN Plus were introduced in Masvingo, with PEN starting in 2018, PEN Plus starting in 2022, and in 2024, we had more like an integrated model for both PEN and PEN Plus. And now it's 2026, both programs are focusing on scale up, with PEN scaling up to more than 200 facilities, while PEN Plus is scaling up to more than 10 district hospitals. And for these two to coexist, we must talk about the referral pathway. So as you can see, this referral pathway, it covers from both the community level up to the higher tertiary care. So at community level, these two programs, they coexist, because at community level there is case finding for both groups, the PEN and PEN plus. There is patient follow-up within the community. There is also